Dr. Garcia-Tsao, what are the main indications and contraindications of non-selective beta blockers in patients with cirrhosis?
So the main indications for beta blockers, actually, beta blockers are perhaps the most important medication that we have for portal hypertension at this time. And so in the patient who has compensated cirrhosis, it has recently been shown that beta blockers can actually prevent decompensation, not only variceal hemorrhage, but also ascites, which is the most common complicating event. Now, in patients who have high-risk varices, beta blockers have been shown to decrease the rate of first variceal hemorrhage, and therefore, because it acts on the pathophysiology of portal hypertension by reducing portal pressure, it is going to be a much more rational therapy than, for example, ligating those varices, because this was going to be a local therapy. Now, in the setting of someone who has bled, once the bleeding has resolved, and assuming that the patient did not get TIPS during the acute variceal hemorrhage, beta blockers are the key component of combination therapy to prevent a repeat bleeding episode. The therapy then is beta blockers plus ligation. Now, so the indications is any patient with cirrhosis, compensated or decompensated, or with or without varices, and in patients who have bled from varices. Now, what are the contraindications? In my mind, the only contraindication is the patient gets hypotensive on the beta blocker. There's other contraindications, which is, for example, the patient who has asthma, which may exacerbate asthma, or the patient who already has a very low heart rate and they become syncopal or with other cardiovascular symptoms in the presence of beta blockers.
In your talk, you brought up the topic of the use of statins in portal hypertension, and you said better be used with caution. Can you talk about that?
Yes. So in patients, so in general, statins have they act in a separate place than the beta blockers. Beta blockers act by decreasing flow. Statins act by decreasing intrahepatic resistance. So therefore, the use of statins plus beta blockers seems attractive because they act at different levels. Now, statins in the compensated patient, they are safe. They do not produce hepatotoxicity, and in fact, in patients who have NASH, actually they bring down, by controlling hyperlipidemia, they actually improve the aminotransferases. However, in the patients that's decompensated, particularly patients who are jaundiced or are decompensated, doses of 40 milligrams or more of simvastatin have been associated with significant rhabdomyolysis. So it's not really hepatotoxicity, but what happens is they damages the muscle, and therefore these patients can get into trouble by getting rhabdomyolysis and kidney failure from this. So one has to be cautious in these patients, and we have to wait for further trials in these patients to see what exactly is the group of patients with cirrhosis that are going to be candidates for treatment with statins.
And lastly, you talked at this meeting about getting published. What's the take-home message on that?
It's about doing the study that is a carefully done study in which the author thinks that there's something to communicate to the hepatology community, something that is going to be useful for them, that is going to advance the knowledge, or that's going to change the practice of patients. The key is not just publishing for the publishing's sake, but publishing because there's something to communicate.
Thank you.
We're doing